Good evening, everyone, and welcome to the Alex MO I Am a PT podcast. We have created a website, and you can see on the bottom at the banner www.thealexmopodcast.com. You can visit us and see all our past episodes and the list of our upcoming guests. Also, you can find us on Twitter at the We are also on Instagram at the and please don't forget to subscribe to our YouTube channel. So, tonight, Alex and I are so honored to have as our guest none other than Cindy Krafft, PT. I know I met her over 7 years ago at my first combined section meeting as a professional in Anaheim, California. I sat during one of her sessions, and I believe that was the first time I actually met Alex in person as well, too.
I was going to say that
Yes.
that Anaheim CSM was a big one for you.
Mm-hmm.
Yeah, and I sat during one of your hot topics session, and I was like jolted. I was like fired up, and I was like, "Damn, this one was not playing." So I know I needed to step. I know I needed to step my game up as a clinician, and knowing that I was about to start my own business, I knew I had to be up to date on all the latest clinical issues related to home health. And it has definitely been a privilege being a colleague of both you and Dee Conetti, because I have been informed a lot all the way, being a young practicing home health clinician. So we are indeed excited to have you on the show.
Yes.
Well, I'm excited to be here as well. I missed Hot Topics this last CSM, so I'm looking to work some of that in today.
Good deal, good
Great,
deal.
great.
Well, as Mo
So
said, thank you very much for joining us. This is, I'm sure we probably even interacted on Twitter, but actually face to face, this is the first time that we get to meet. So it's definitely a pleasure. Have heard great things about you. You know, I keep up with what you got going on. So it's definitely very impressive with the ever changing scope of home health. Obviously, you know, in the little video that you did for us to kind of promote this episode, you mentioned you've been a PT for 30 years and you've done home health for 28. Is that correct?
That is correct. And that was never the career path I thought I was going to take, Alex. It was, I was going to work in a big facility in a big city, working with traumatic brain injured. I loved the neuro population. That was always what I thought I was going to do through PT school. And then life took a different direction, and having a couple small kids, they were like, well, why don't you do home care? And I'm like, ew, gross. No. I'm not going to. I argued for over a year. I said, no, I'm not going to get mugged and fight roaches and all that other. No way. And then it was like, well, there's flexibility. I'll try a little PRN, and I've never gone back. And I'm pretty sure that no facility would actually take me back at this point. I think I'm going to be a lifer in this setting because I just love the practicality, and that every day is different in good ways and challenging ways, but really able to work with people where they really are. And then, you know, that kind of makes it difficult when you visit a facility that has the simulated stuff and you want to kind of go, yeah, nobody lives like that. Nobody has 99 grab bars in their bathroom. I'm just going to point it out. They really don't. So yeah, I had to figure out, because it's interesting when I was doing the math this morning for that, Alex, I realized, because I always have to figure it out by the age of one of my children. Ironically, he is also now a PTA and he works in home health.
That's awesome. So you have, what you mentioned, 2 kids?
I have 4.
Oh, 4. More power to you.
Typically
I got 2 and I think I'm going crazy sometimes.
I have none, so I'm sort of free as a bird.
Well, my non-home health related advice is, to me, the biggest challenge was from 2 to 3, because then you were outnumbered. By 4, you're just like,
yeah,
there's more of them than there are us anyway. So at least now it's 2 and 2. I don't feel like I got 2 and you got 1, which seems unfair. So
yeah.
At least divide it up a little bit.
Good deal. So where did you start practicing?
I started practicing in an agency in northern Indiana. It was nearby where I had originally gone to school. The challenges there were winter, which any home health clinician knows that that's interesting. I always used to swear we got to figure out a way how to safely make shoveling a cardiac related goal to get these people to actually shovel before we got there. But yeah, and at that time it was, ye old days of paper documentation, of writing really hard on NCR copy, so you got the barely readable version on the back, and literally finding patients' homes with physical maps.
Well, see, it's funny you said that because when you mentioned the time you've been doing it, I'm like, man, like trying to get to a patient's home using probably MapQuest, and you've got about
Oh, it
30.
was pre-MapQuest. No, we're talking you had to go buy the book, and figure out and write it all out. MapQuest was a step up, but that only worked if patients stuck to the schedule in order. Because if they said, "Oh, I don't want to be seen till tomorrow," and you try to pull one, now your directions between house to house were wrong.
Are gone.
They're just toast. There was
Yeah.
no
Wow.
recalculating feature with the MapQuest. So now that I feel really old, no, but I look at that now and I'm like, GPS, boy, that would have made it. I mean, even now, some of the EMRs have put in the patients for the day and they'll organize them in the right order. I'm like, man, I could have been much more efficient than that book. Although it does make me lazy because I used to be really good with maps, and now my husband will be, which way are we going, north? Or I'm like, I don't know, where's the sun? I don't know
Wherever
now.
that little voice says to go.
Yeah, wherever they say go, I'm going.
I see. Well, when I first started home health, it seemed to me like it was mostly people who were about to retire, or mostly moms who wanted flexible schedules that practice in home health. So to hear you say that that was one of the first settings that you went into, it's pretty amazing. Because I started in an outpatient setting, and I know it's the same for Alex. So one of the reasons why is that I wanted to do more one-on-one care. And I did get a bit frustrated when patients had home health and they came into outpatient, that I didn't believe they were in a place that they needed to be after receiving maybe 6 weeks of home health or 8 weeks of home health.
Mm-hmm.
And as I said before, your session jolted me because it pretty much matched up to the things that I was saying, in that sometimes we are scared to challenge patients and we just see if we go in and they're bedridden or chair bound, that we just do, simple exercises and not challenge them to be up and sitting up and moving around. So it's amazing to hear that you started right out doing that.
Well, and also at that point, the patients getting therapy were pretty much your hips, knees, and strokes. I mean, it was the very straightforward, very, limited view of what therapy could do. And I remember sitting in case conferences thinking, wait a minute, you're talking that this person has fallen twice. And, oh, but that's not a therapy patient. What do you mean that's not a therapy patient? Well, he didn't have a joint replaced. Okay, this is not about the diagnosis. This is about, you're talking about individuals with heart failure, COPD, they're falling, they're having mobility impairment. Why would you not want them at least evaluated? And it's ironic to me that nearly 30 years later, I'm still telling agencies, I'm not trying to oversimplify this, but patients qualify for home health overwhelmingly to comply with the regulation. You're saying that they have a mobility impairment. I mean, you can qualify through a cognitive behavioral issue. You can qualify with a homebound restriction related to infection, which we saw a lot more of during COVID. But overwhelmingly, you're documenting this patient has a physical impairment limiting their ability to access care. Well, why would that not in and of itself warrant an evaluation to figure out, is this something that we can move the needle to improvement, that we need to be in there to stabilize? I mean, I think it's odd to still think that there's therapy patients. And I'd like to say, oh, that's gone now. But I still work with agencies that are believing that only the groupers in the current payment methodology that have rehab in the title, so musculoskeletal and neuro, are the only ones that are supposed to get therapy. So it's been a journey, but I think a lot of it is how do we get high quality PTs and PTAs to come in this setting and embrace that setting? Because I could take it a step further, Monique, than the retirement and mom category. I in my previous life as a rehab director, two interviews of candidates always stick out in my mind. One told me that home health was a place for old therapists to go to die. That's what he was trying to get a job. Keep this in mind. He was trying to get a job. And
As
that's what he said to me.
in the home health agency?
Yes.
Okay.
Yes. Yeah. And then the other one told me that she'd like to do home health, but she'd have to give up her skills.
Whoa.
Yeah. When I talk to PT students, I say, listen, no matter what they tell you about the job market, you still can't say that kind of stuff and expect to get a job. I'm just saying, because that is not the fit in this setting to say I can, get by on the bare minimum, or I'd have to give up. So I couldn't help myself. I said, so what are your skills? I'm thinking, oh, magic one. Well, I, specialize in lymphedema management and managing incontinence. Oh, well, that's too bad because, we don't have any of that in home care. So
that's only
that's not an issue. So bye. Because it's like, But I think that kind of feeling still exists to a certain degree, that it's sometimes so much about flexibility and autonomy that we're not getting the right fit to say there's a huge level of responsibility that comes with that you have to practice, as Dee always says, at the top of your license. And you are really managing people. I early on in my career would talk with acute care therapists and say, we have a lot more in common than I think these two settings ever really collaborate on, in terms of what you have to manage the acuity of the patient and how you have to think about structuring their care at that point in time. Because you're right, Monique, I can't take any more ankle pump home programs. I just can't. The ankle pumps it's going to be on my tombstone. It's going to be some cutout of an ankle pump. But Alex, I don't know if you've heard this one. The one that put me over the edge forever was a therapist who that was the cornerstone of their exercise program. And the primary diagnosis was vaginitis. So these have very magical powers, apparently.
Yeah.
Ankle pumps will cure everything.
Sure. Yeah.
So
circulation.
It's interesting, obviously, you mentioned that a life situation is what kind of pointed you in this direction. Mo and I have discussed, and as Mo mentioned, I started an outpatient. I was doing outpatient, loving life. I ended up getting a job working for special operations here in MacDill Air Force Base, because I'm in Tampa. And then Congress cut funding to the program. So now I don't have a job. So I need to kind of pivot and find something kind of quickly. But I knew that I didn't want to do outpatient, mainly because I had been there long enough to understand the business, to say that unless you are like an owner or in a environment or a setup that gives you some sort of stake, you're never really going to make good money. And not that any of us come into physical therapy wanting to make, or expecting to make six figures, although depending on who you talk to, some may feel that way. I just knew that wasn't it. So here comes home health. And similar to you, like if you would have told me like, hey, Alex, you're going to be doing home health, I would have been like, you're crazy. I'm going to be working with some high school athlete or whatever. Because I did a sports residency when I finished PT school. And I gravitated towards it. I love it. I don't think I wouldn't want to go anywhere else right now. Flexibility is the most, to me, the most priceless part of this job. For instance, this morning, my son needed to go to the doctor. I was able to just push my whole day back, get my son to the doctor, do what I need to do, and then go about my business. And to see obviously what you've been able to do, and what Mo's doing as well. I mean, I've always kind of stayed to, I don't really feel like managing other people or handling that side of it. I just want to see the patients, do what I got to do, make the business grow and do those things same. So I guess that leads me to a point. My question is, at what point did you figure out or believe like there's a need here and I need to now pivot to try to fill that need to kind of get you to where you are today?
I would say, because that it was back to that very first agency where I was working, and there was no representation in leadership. It was the classic definition of a visiting nurse association. Everything was nurse, 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 24/7. I used to threaten to go out and put, and therapist out on the front sign because it just everything was so nursing. And so it was trying to make the case that therapy isn't more special than nursing, but it's different. And that you need a therapy voice, at least in the conversation, because some of the plans you're coming up with work great for nursing. They just don't work the same for therapy. I think scheduling remains a great example of that. Nursing tends to be very centralized. Here, scheduler, here's the patients, you figure it out. We tend to hate that. We want to self-schedule so that we can plan the day and have that level of continuity. So I just kept pushing on that. And then it was, okay, well, if you're not making visits, because at that time, another how old I am, the home health was paid per visit. So obviously visits is what they wanted you to make because that's when went on the claim, is that if I'm in here doing meetings, then they can't bill visits. So it was a process of, okay, there can be a team leader. And then it was, oh, well, there's value in this. There could be a rehab supervisor. So it kind of grew organically that way. And then I got a cold call from a recruiter at one point who was looking for a rehab director for a home health agency that had 6 locations at the time in another state. And so after, much discussion with my husband, we relocated and I took that position, which was very different, dealing with multiple locations, urban, rural, in the central part of Illinois. And then I don't even know what possessed me one day. I decided I was going to submit to do a presentation for the Illinois Home Care Council annual meeting. Figured they'd never take it. And they did. And I was a nervous wreck. My husband went with me and I told him I wasn't getting out of the car because I was going to throw up. There was no way I was going to stand in front of a room full of people and talk about anything. But I made myself do it. And the response of people of, could you come to my agency and talk about that? I'm from neighboring Indiana. Would you come talk about that? It just kind of snowballed from there. And it was realizing that I can make a difference in my one agency, or like you said, Monique, you realize there's other issues bigger, and there has to be a voice to try to say, listen, we can do better than this. Or we're not saying we're special and you have to, kiss the ring when a therapist shows up, but we do think differently and we work better together in collaboration with other disciplines, not sitting in a corner arguing that, I'm not checking their medications, I'm not looking at wounds, I'm not doing this. Okay, we need to be a better team player. And that really became a passion of mine. And then then along the journey, I don't want to take up too much time on this train, but the other element, Alex, was I had the opportunity to sit through my first state survey. And I'm listening to this surveyor say, well, this rule and that rule. And I'm like, what rule? I want to see it. So I'd go look and I'd go to the administrator and I'm like, she's wrong. This is what the rule says. I think she's making that up, or it's her interpretation. And it lit a fire in me that said, listen, we have enough rules in home care. We don't need all the fake myth ones that people come up with, or were true 5 years ago, or is really an agency policy and not a real rule. So I am very passionate about anytime somebody says it's a rule, please show me. I mean, I'm not trying to fight with you. I just would like to see that Medicare said that.
I'm
and if
with you on that, because Mo knows, like, I'll make comments on Twitter. Like, it drives me nuts when people are like, oh, it's a CMS rule, it's a Medicare rule. I'm like, show me where it says that. Like,
it's even better, Alex. I love it better when they come back with a handout of a presentation.
Yeah.
That's not a rule.
If you want to make it an agency rule, that's fine. Yep. But call it that. Mm-hmm. Don't just pull Medicare into this to make it seem more legit. And that to me is the most frustrating thing when I'm dealing with, here I deal with a lot of smaller agencies, a lot of um, mom and pop type agencies. And in Florida, we get a lot of fraud, obviously, and a lot of things that have happened in the state. So people are very, very weary about rules. But then they're like,
Right.
well, no, it's a Medicare rule. I'm like, no, show me where it says that it's a Medicare, and they never can. They're like, oh, Medicare. I'm like, no. If you want to make it your rule, that's fine.
Right.
I'll follow your rules. But
Just own it's your rule.
Don't say exactly. Don't make up rules and say that it's Medicare.
Well, that's one of my favorite things, because I'll get emails. I've been looking for this rule, blah, blah, blah. I can't find it anywhere. So at what point do you have to realize it doesn't exist? That's why you can't find it anywhere. You've checked everywhere reputable. It is nowhere. And they'll come to me with, I know this is a rule. No one can find it, because it's not. Again, it could be an agency policy, and it could be a very good agency policy, but rules are one thing and policy is something else. And so that just became a huge issue with me about, this setting. I think there's challenges clinically, but the bigger challenge to me is when PTs and PTAs hunker down with, I'm just going to do therapy, just like I would everywhere else. And it's like, wait a minute, you do need to understand the rules that apply to the setting, no matter what your setting is. You need to know what they are. So when individuals say, I just do what the SNF told me, okay, your name and your license is on this stuff. So you have to be responsible, and to stick your head in the sand and say, well, my boss will just tell me, if something's not what I should be doing, they'll just tell me. It's like, no, that's not how this works. And then by extension, I got addicted to Oasis, which might be a quantifiable mental illness to many people. But yeah, I might be one of the few people that is very excited about Oasis E. But
see, it's funny that you mentioned that. Like, I don't know that Oasis changed within the last 4 or 5 years, maybe.
It's been a while. Yeah.
It was when they started to add all the
moves.
Yeah,
the GG ones went in there.
The GG ones, correct.
Yeah.
The GG ones went in.
So Oasis E is supposed to start in the beginning of the year.
Yep, January 1, 2023.
And if you could, this is probably easier said than done, but what's the biggest difference with E as to opposed to what we're doing now?
Well, what I like to say is we need to just calm down a little bit, because as soon as you say there's a new Oasis, everybody loves the current. Oh, I don't want to change it. This one's perfect. It's like, really, you hated it 10 minutes ago, but okay. As opposed to freaking out because it's a new letter, I've literally gone in and counted the items. 75% of Oasis E is Oasis D. We're already doing 75% of it. So if I've mastered that and I'm not getting a bunch of corrections and I understand what it is and it's all good, I'm already 75% ready for January 1, 2023. And I think that helps change the conversation, because a lot of Oasis change tends to bring about fear mongering. Oh, there's a new one. You're going to have all this training. You will on 25% of it. And on all of it, if you haven't been understanding the current one, and get a bunch of corrections. But if you've got that under control, it's really just the remaining 25%. And what we're seeing in that additional part are inclusion of things about social determinants of health. We're seeing more testing built into cognitive behavioral issues. So as opposed to a general forgetful type comment, it is guiding towards specific screening tools. And the PHQ-2 for depression is now the 9. I mean, they've built the 9 in there. So I think a lot of it is good progress. I mean, that those are changes that should have been made. And I think things that are going away are things that should have gone away. I mean, the old vision question has been unchanged for 20 plus years, but it always stayed there because it was a payment related issue in the previous payment model. Now that it's not in PDGM, there are vision questions, but they're much better vision questions. They're much more practical vision questions. So I think a lot of the changes are for the better. My aggravation is that any question that factors into payment or outcome measures, they don't change. So the entire functional assessment, whether it's the M questions or the GG questions, is identical.
Mm.
And some may say, yay, I like the stability. Some may say, those questions were broke. And can we, why couldn't you fix 1860 to stop saying requires a two-handed device and then have the guidance say it doesn't really mean requires a two-handed device? Why can't you just fix the question? Because it all impacts how points are garnered in PDGM. It's teed up to value-based purchasing, so they don't touch it. So I think we're seeing where the changed ones are going to make more sense and may make us a little more aggravated with some of the things that didn't get changed, but at least they'll be the same. 75% of what we're doing today will be there as well.
Hmm. Well, one of the complaints that you get from many physical therapists is that documentation is always tedious. And as you mentioned before, a lot of them say they just want to do therapy when they go into a patient's house. So I know change is sort of fearful for a lot of people. So I'm glad you took the time to explain Oasis E. I'm hoping that agencies that many of our listeners work for will take the time to explain this and not make people fearful and run in fear and quit
Right.
doing home health because of minor changes. As you said, 75% of it is still gonna be there.
Mm-hmm.
And honestly, I think there's always improvement on a product or service delivery because documentation is how we do get paid. So when you talk about value purchasing, in the simplest of ways, how would you explain that to our listeners?
Well, I would recommend when you're thinking about value-based purchasing is to look at the summary report. And I can send you guys the link and you guys can post wherever you want to post it. But there was a demonstration project first. And I actually was on one of the technical expert panels early on with the value-based purchasing model. And we can see that even in the middle of the pandemic, the language was coming out that they were going to expand this, that they intended to expand it, and it was going to go to all 50 states. The summary report, I think, is incredibly interesting because what it says is that there was some change in quality in the demonstration states versus the other. Nominal change. It wasn't like they were astronomically higher quality. So you would say, well, wait a minute, you call it value-based purchasing. So if there wasn't a huge change in value in terms of quality, why did you continue? Well, because as you read on, they saved a lot of money reducing rehospitalization and keeping people out of the skilled nursing facilities. They even owned up to the fact that they spent more in ED visits. So there were more ED visits, there was a higher cost of observation status, a whole other conversation. But when you look at it, it says, wait a minute, quality is important in this model, but the bigger ticket item is, did you keep them out of the hospital? Did you prevent them from being in a skilled nursing facility? So speaking to therapists, my concern about value-based purchasing is that agencies are going to where they're comfortable, which is let's look at the outcomes. Oh yes, there's functional outcomes. That means therapy is going to be responsible for the functional outcomes that this thing measures. And I always say we'd be happy to. Are you going to refer 100% of your Medicare patients for a PT eval? Because unless we see them all, cannot be solely responsible for the outcome. I mean, I think that's fair. I mean, you can't hold me responsible and only let me see half the patients. I mean, then we're sharing responsibility. But then it goes back to this whole, you're going to have to improve people. You're going to have to get improvement. What I like about value-based purchasing versus our current STARS business is that function is going to be in composite scores. A composite score related to self-care, a composite score related to mobility. So it's no longer implying that you have to get every single one of these measures to improve to be a positive. It's as a group, do you have a net gain? But that still brings in the issue of maintenance. So Cornetti and Krafft, Dee and I have been talking about maintenance for a long time. And now it's, well, where would maintenance fit in value then? If you're going to go in to stabilize this, then this doesn't work in value-based purchasing, which is why I go back to what I said a moment ago. The biggest push, did you keep them out of the hospital? Did you keep them out of a nursing home? So I think as home health therapists, I'm not saying it radically changes our care delivery in terms of interventions, but it needs to get us thinking about on every single visit, what am I specifically doing for this individual to reduce their risk of higher cost care? So what about them causes concern that they could go back to the hospital? What about them leads you to believe if I don't do something, this could be a path to a skilled nursing facility? If we can tie ourselves into that in the new model and stop getting pigeonholed that the only thing we can do is directly address function, we will be in a much better position. And that's what CMS is expecting. They don't build value-based purchasing as a nursing incentivized program. They're saying, you do whatever you guys do best to reduce the risk of them costing us more money. I mean, that's really at the end of the day. But I see a lot of therapists go back to, okay, so we're responsible then for walking and bathing and transferring. Can you think bigger about maybe that taking their vital signs before you did anything and realizing you are not stable enough to put you through this program today? You're just not. So we're going to talk about other strategies. We're going to talk about what to do when you don't have a good day. All of it's skilled. But my value is if I went in there and didn't check your vitals and just told you get up, run around and do some ankle pumps, I could have put you in the hospital. So am I really looking at individually, what are we doing for this person today? And when this visit is ending, have I done to the best of my ability, mitigated all risks? So if that dressing was half hanging off and I went, the nurse is coming tomorrow, they can deal with it, what risk have I created? And this is where I think in our setting, it's, yes, I'm doing therapy, but I'm doing it in a situation where I have to be on high alert for any other potential issue. And I think that's where some folks misunderstand and say they're trying to make me a nurse. Nobody's trying to make you a nurse. You have to be aware enough to say, oh, that doesn't look right. I'm calling a nurse. That is definitely not right. I'm calling the doctor. I'm not now taking responsibility for the minutia of every single issue, but to say I don't see any of it, I'm just going to do my exercises and ambulation, you're actually creating risk. So I think that value-based purchasing doesn't make us do anything crazy different, but it's got to make us think about what am I doing directed toward those types of outcomes.
What I was gonna say, so sorry for interrupting you, is that a lot of us want to practice in a silo, and I think value-based purchasing is gonna try to hopefully push us in the direction of wanting to see the value of nursing, the value of occupational therapy, even the value of social work. Because if a patient is not getting their basic needs met or getting resources to their home, they're never going to be truly satisfied about the outcome that you get. Yeah, you could be able to get them stronger and they can be able to transfer and get out of bed independently or go up and down the stairs. But if they don't have meals that is going to sustain them 5 days a week or transportation to go to and from the doctors or other medical appointments, they're gonna feel like home health didn't help them. So as physical therapists, we have to better understand the role of other disciplines as well in order to be able to improve that value purchasing as well.
Well, without knowing it, you actually poke the bear with that, Monique, because in Oasis E, there's a question that specifically addresses is there a transportation issue impacting the patient's ability to get food or medicine? And I have had more than one agency already complain to me, oh, with that new stuff in Oasis E, now we're going to have to put it in the care plan. Now the admitting nurse is going to have to follow up on this, that, or the other. We're going to have to build goals. We're going to have to build interventions. And I'm glad the video was off when I was talking to these people, because I'm like, first of all, are you telling me you don't check that now? Like the person can't get food, can't get medicine, and you aren't paying attention to that at all at the moment? Because that's a little frightening. The fact you immediately think it turns into an EMR solution, why would you not say, if I've done that question and the patient has that problem, get a social worker order? I mean, why are we ordering social work chronically? Is I've literally read thousands of charts. If they're ordered at all, they're ordered like a week before discharge. In a panic, what are we going to do now? It's like you knew they lived alone when you admitted them. Why did you take this long? So I've been trying to spin E, and that fits with what you just said about reducing rehospitalization. Why is your instinct to go, oh gosh, this is more work? um, why would you not be checking for these things? And then who on my team is best suited? I said, you're already complaining of a nursing shortage. If you just make a whole other page to their care plan that's about figuring out a transportation problem, why would that be the nurse's job? I don't even see necessarily as a therapist's job. Why would we not say on a therapy admission, uh-oh, I see this, I'm getting a social worker? I
Well, the
mean, it makes
challenge
more
is that
sense.
a lot of us don't know what the role of a social worker is or what they do. So there's hardly any recommendation of it. So I do believe if agencies do in services to let people know exactly what the role of a social worker is, what the role of a nurse is, what the role of a OT is, and the role of a PT, there could be better communication. And as you said earlier on when we were talking, um, interdisciplinary team meetings
Mhm.
and case management, because I'm telling you, I've seen some lousy case managing, and I can feel sorry for some patients. You know, you try to step in and take over, but you don't want people to say, "Look, you're encroaching on my territory." But I want to pose another hot issue to you, because I'm seeing a lot of new grads or students asking about home health because they're
Mhm.
being told that it's one of the setting that pays a lot of money. It pays more than outpatient or acute care. So a lot of them are interested in it and wanting to get into it. But there is a lot of autonomy. And so, what you were once a rehab director, what qualities do you look for, or are you looking for if you were to hire someone to practice in the home health setting, knowing
Well,
what you are looking for?
Well, actually, Monique, I go back to my alma mater every year and do a 4-hour block on home health as part of their geriatric. I actually have a slide that's a checklist for what that new professional should be looking for in the agency and what
Mhm.
they should be looking for it themselves. And I'm happy to share that with you guys, and you can do what you want with it. But I think the issue here is I need to be looking at my own comfort level with that kind of autonomy. I encourage new professionals that if the agency is very quick to just offer you a job without a lot of questions, you should be afraid, because that just means you're alive and you're licensed. You need to ask about, how many other therapists are there. I've seen small agencies try to hire a new grad and they're the only PT. I have a hard time with that. Again, flipping the rehab director hat. If you're going to do that, and that's based on size, one is all. Then what? Where can you network them? Can you network them to an outpatient provider? Can you network them into a hospital system? I'd be really uncomfortable with a brand new person that wasn't supported. Because you are, no matter how much, I think we all have perspective different on how prepared we were early on. At the time, many of us thought we were all that in a bag of chips. In hindsight, you're like, you know enough to be dangerous. You know enough now. You can put on your white coat all you want to. Um, you got a little work to do before you got the street cred. So it's making sure, and that's why I never say you can't do it, but you got to look at warning signs. You got to ask the question: how big is this service area? How many patients do you expect me to see in a day? How much time do you want me to spend with them? That kind of thing. And as a rehab director, I mean, you want to be very clear with those expectations, and that you want them to spend time with the patients. I still encounter I'm able to do 15 to 17 visits a day. And I'm like, let me guess, you're paid per visit, right? Yeah. And your visit length is under 30 minutes. That's not a model that we want to perpetuate. So I think it's about how comfortable am I, and do I have that ability to network? And we've seen some home health agencies really try to embrace that with mentorship programs of partnering people up to be able to have that level of support, because home health is autonomous anyway. And if you don't really have someone to bounce those ideas off of, it can get very overwhelming very fast. But I tell students all the time, I loved taking students in home care because one of two things is going to happen. One of two things. Either you're going to say, I love it, and someday I want to do it. The other camp will say, I don't think I ever want to do this, but I now understand what home health looks like. So it changes how I view my role as an outpatient therapist as I look, because I was an outpatient briefly, and I look back and say, oh, I thought those people asleep in the lobby, maybe weren't particularly motivated. Maybe they should have been in home health for a period of time and then been ready to come and participate in outpatient. So I think as a student, I encourage them, if you have the ability to do a rotation or go out or do a ride along or call up an agency and see if they'll take you on a ride along, it really gives you a perspective that you take with you, even if you don't ever go back and work there, to really understand what that functional situation is in somebody's home. Because it does not look like any simulated gym setup ever.
No, and I think to your point earlier about looking at the individual as a whole, not just with our our blinders on, where we're just like, I'm here to walk you and to help you get up from this chair. Like, that's one of the biggest things that I had to learn, but now I really appreciate, is the ability to help this individual as a whole, as a person, as opposed to just whatever impairments they may have. Because, depending on the area that you're going to see patients, like I see a good amount of patients in a lower socioeconomic part of Tampa, and some of their issues go far beyond, getting up and walking. Some of them have trouble getting to their doctor's appointments, have trouble getting their medicine, to get to the house somehow, whether it's a family member picking it up or them getting driven. So you've got to understand those things and be able to know how to get the resources to those individuals. And that's where like a consult for a social worker may come through. But yeah, if you're just a newer therapist or even seasoned therapist that just never done home health before, that can get overwhelming pretty quickly and have you running the other way. And it's purely just because you don't know, you've never been in that position. You don't know how to handle it. And having those resources, whether it be mentorship and stuff like that. I know, like, we like to on here, promote, and it happens quite a bit just via Twitter. We've had conversations back and forth where individuals would just say, hey, I had this patient, this came up.
Right.
What do you guys think? And I do think that's a big plus to social media, and specifically Twitter for the PT world. But yeah, home health, you're on an island. And if you don't have those resources or people that you can pick up the phone and say, hey, this is what's going on. What do I need to do here? What do you recommend? Yeah, it can get very, very overwhelming. And at the end of the day, the person that ends up losing, so to speak, is the patient, because they're not getting the best care possible.
Well, I think a couple things there, Alex. I think that having that network of reaching out to individuals like the both of you is a huge positive. I think that people need to be careful on social media who they get that opinion from, because I've also seen it go the other way, which is refuse to do admits unless they pay you $250. It's like, what? I mean, or you tell them you don't do this, or you just walk away, and it's like, okay, whoa. Maybe you ought to screen who you asked, or, back to what we were saying earlier, Alex, when somebody busts out a rule, it's like, can you put a citation, please? Because I'm, again, not sure that was a real rule or you just made that up.
Yeah.
But I also think, managing them in the home, we have to understand the patient perception of therapy as well, which is overwhelmingly a variation of, we're going to show up wearing spandex and a whistle and say, drop and give me 20. I mean, so these are individuals more often than not that have come home from the hospital, home from the nursing home, don't feel well. They're afraid of us. they're afraid we're going to come in and make them feel worse. And so I think that making the connection and the practicality of what we're trying to get you to do is not just exercise for the sake of, we find it amusing to make you do this, but what do you want to get out of this? And I think that's what keeps me in this setting, because it was so frustrating being in acute care, being in outpatient. I felt like I couldn't get that connection. It was your name, and especially acute care. And no offense, it just, for me, the frustration was, I don't know your name. You're a procedure. That's all I got, because you're in and out so fast that I really can get no handle on what you're trying to get out of this, other than good enough to get away from me so that you can go home.
Good enough to get discharged. Good enough so they
Right.
feel comfortable that they check the box.
Well, and that doesn't work to our favor either sometimes, Alex, because they've met their goal. I am in my recliner with my chair and my cat and my TV. My goal's met. So it's like, so what else do you want to do? And that's the creativity part I like, is to say, I got to kind of check my ego differently here. I have tools that are uniquely my discipline to help you, but I will get nowhere until we figure out what is meaningful to you. And that's where, that's kind of a documentation thing, Monique. I've asked many, many therapists, PTs and OTs in particular, how many of your patients have a pet in home health? And then the eye rolls start. Everybody's got the crazy pet story, but they're like, oh, 80%, 85%, 90%. I'm like, interesting. So are there any functional related goals or things or problems related to pet management? Oh, yeah. Okay, so I've been in this space reviewing documentation for the better part of 20 of these 28 years, and I have only ever seen 2 therapy care plans that reference to pet. What's the disconnect? I mean, Medicare says you need to be functionally relevant. How more meaningful could it be to engage that patient, and how do we strategize for you to safely get that dog in and out the back door? Because we know they like that dog better than us, and if we don't address it, they're going to do it anyway. So what is the plan? And yeah, I can do my magical therapy skills, but if we're contextualizing it into something that relevant, I think it's a huge trust builder for patients. Although I did read once where the PT put that he recommended the patient get rid of the dog, which I know this will be a shock. There were no further visits from that PT. So I'm pretty sure the patient evicted that individual and said, send me somebody else, because that's not happening. But I think it's a good example. Sometimes we get very tied up in documentation is frustrating and it's long and my EMR is horrible and blah, blah, blah. Yes, there's work to do there, but can we bring it back to what is the focus? And if patients are that engaged with pet management, why would we not consider that as a focus of our care plan, at least initially, to build that? I'm not just having you, stand up and down 5 times because I think it's funny. If you can do this better, that I'm less concerned. And maybe the dog food bowl needs to move a little bit, because you bending over like that and letting go of your assistive device is a terrible idea. I know that's how you've done it before. Let's figure out a better way to do it so you don't fall, break a hip, and go to the hospital.
That's interesting, because most agencies have policies where you put away your pet at the time of the evaluation or admission, and
we know when they come back out, you're on the driveway, they're already back out.
I know. Well, I had an interesting incident a few weeks ago where a patient who was post kidney transplant, she has I think it was a lab, a chocolate lab. But she usually kept the door open, just a screen door. And the dog got away from her before she could get him in the back. And as soon as I opened the screen door, I wasn't expecting the dog to come. So it's like she jumped up and I was like, oh, and she just started running down the street without a leash. So I had to go chasing after the dog. So that was my therapy for the day. So
I always felt, though, that I was more concerned about the little dogs, especially if they're wearing sweaters. Now you're in a whole other level of, that's a family member, and they'll tell you, oh, they don't bite. Yeah, they don't bite you, and they're right by your legs where I am going to reach to assess you, and I'd like to keep all my fingers. But yeah, I totally get that we ask them to put them up. But it ties right into another issue. We also tell people before an admission to get all your medication and put it into one spot. Oh, because that's easier. Okay, where do you normally keep your medication? Because part of managing the medication is mobility related. So why would I not, as a PT, do all my wonderful gait assessment thing? And where do you keep your medicine? Oh, upstairs, downstairs, in the basement, in the garage. Great. You failed all my standardized tests and you can't get across the room. How are you going all over the house for these medicines? Oh, I miss them once in a while. Then my daughter comes by. Now we have med errors. So it's not always, oh my gosh, it's medication, it's a nurse. It's where where are we stepping up where gait in home health can have a direct relationship to a medication error because, oh, my back was hurting, or and I know you got people watching this going, I know, crazy lady. I tell them to move the medicine. That's called a skilled intervention. It is. They would have put it all over the place without your help. You suggest moving it. You have now improved the situation. Their baseline was a problem, and you fixed medication off of mobility issue without ever having to get into any of the other stuff about their medication profile. So I think those are two of the, sometimes we develop these habits that make sense, and I'm not saying they're wrong, but we got to be thinking about that pet coming back out when I'm gone, that medicine is going to go back where you put it. Where do you normally keep it? Oh my gosh, you let go of the walker to carry that basket and go put it all away. Now I see a risk behavior.
Yeah,
Most
very good
definitely.
points. I mean, a lot of things we don't think about, and obviously why we need people like yourself to help kind of bridge those gaps. Because, yeah, there's a lot more mobility based things that happen in the day to day lives of our patients that we don't even realize to say to make that connection.
Well, because I think we're often seen as the don't ever take your hands off the assistive device people, right? We don't tell them to let it go. But in their home, there's things they have to do that they're gonna let it go. So what happens when what is the safest way to let it go? Where should you park that thing instead of where I can clearly see you park it outside the bathroom door, and where you position it before you go in the kitchen? But is that the best spot? Because I know you're going to have to let go of it at some point. And what is that going to look like? How do we minimize risk for that? Because sometimes I think we are the don't let go, don't let go, don't let go. And then they don't know what to do when they've got to let go. We haven't really addressed the safest possible way to do that. And I don't think, again, you don't really see that in a facility situation where I go do my therapy, we take our long walks, and the whole time I have you holding onto that walker, and I don't really think about you letting go, because then I put you back in your bed and I go to the next patient. And they don't really have to do anything because the pills are going to be brought to them, the meal's going to be brought to them. But at home, that's not necessarily what's going to happen. And in some cases, you both know they're going to be the one schlepping the food to somebody else. And it's
Yeah.
because that's been their life role. And it's like, oh my gosh, can we figure out a different way? Because I know you're going to do it. I still would say you shouldn't
Oh,
for now, but you're gonna. So how do we fix it to the best of our ability?
well, I have two sort of hot issues to ask you.
Okay.
One, you mentioned that your son is a physical therapy assistant. And I know I have personally encouraged some to go to PTA before they become a PT if they want to become a PT, and that has been met with some controversy. So, how comfortable were you in encouraging him to become a PTA? I mean, did he want to go all the way to become a PT, or that was his choice to do PTA?
Um, it was his choice. He knows himself well enough that the responsibility of creating a plan and creating the goals was not what he really wanted to do. And he didn't want to be bogged down in all of the assessment related stuff. He wanted to really work with the patients. And he wanted to be more hands on and less the other stuff. Um, but he's also going to me on the regular, why is every care plan just about strengthening? He goes, I need to, I always keep going back to the PT about, because my son started an outpatient as well. So he's like, well, what happened to balance? I mean, there's nothing in here about addressing balance. There's nothing about this. And he says, they're really good about it. He goes, but I'm just a little confused why they've like forgotten a bunch of other stuff. It's always walk them more and get them stronger. And it's like, we're also not going to get them stronger because there's no resistance in this plan anywhere. So it's been interesting. He's very comfortable where he is, but he gets a lot of, so when are you going to be a PT? Well, he's my son. I'm not, and I'm okay with that. But he does get pinged a lot about, like, he's settled. In his mind, that's where he wanted to be, and he's very happy there. Now, it's led to interesting conversations at home. Like, if my husband's back will hurt, I'll say, well, you've been an outpatient more recently than me. Can you take a look at it? You have to do the assessment. I said, what? He goes, I am the assistant. You got to come up with a plan. I said, well, can you give me some insight? I'm not risking my license. I said, okay, seriously, we're in the house. No, that's not my job. You assess, and then you let me know what's going to happen. I'm like, oh my God, seriously. He did that to my mother when she visited. I'm like, oh my gosh, look at her gait. He's like, I don't know. You tell me what you see. I'm like, okay, knock it off. Just look at that and give me some thought. I said, here, I have evaluated. Now, give me something. But yeah, I think there's people that are very, very happy there. And I think it would be very frustrating to have people feel like you settled, or, I mean, I agree with you if that's what you want to do first. But I will tell you, being very candid, when he looks at the student loan issue, he has no regrets at all.
I don't blame him.
He actually has his paid off in 3 years. He's done. And it's like, Mom, I look at what it would be, and he goes, I know that's a whole other hot button issue, and we don't have a lot of time left, but I think that does factor into it.
No.
When you look at that,
that's why I asked you.
I want to see patients. I'm seeing patients. I'm happy as a clam, and I'm not looking at debt that makes me nauseous. So, I think that's going to drive people to make that decision.
Along the PTA issue, I believe there's been either comments or it's actually going to happen to where in the outpatient world, PTA and PT reimbursement is going to be differentiated in some way or somehow. Have you heard about anything like that coming to the home health arena?
Well, actually, we're going on 10 years now that we have had separate codes on the claim for PT versus PTA and OT versus OTA. When that started in 2011, it made a lot of people wonder, what are you doing? I mean, because you're basically tracking it. And I think that, a lot of it it's a little different for us because it's still it's episodic payment. We're not paid by procedure code. But I can kind of see where in any setting, if the payment rate is based on cost, and it went from 50% PT to 50% PTA use to 20% PT and 80% PTA, then you can kind of see where, is this really about the level of patient care or a way to cut costs and improve margins? I've seen home health agencies where states allow it, have 1 PT to 6 full-time PTAs. I don't know how you manage that many caseloads as a PT. I mean, it's technically allowable, but it's concerning. So 11 years in, they haven't pulled the trigger. They haven't talked about it. I think, again, an episodic payment, it's not as much of an issue, but I do think that they've been trying to screen for how much of this is making PT and OT minimal and then just giving everything. And I'm sure you guys have experienced it. I talk to PTs that are like, I never get to keep follow-up visits. I do evals and admits. They don't let me see patients. And I'm like, that's, as the former rehab manager, that always bothered me, that, there are patients that should be kept with a PT, but then at the same time, I would find PTs that were hoarding patients because they figured that way they wouldn't have to do admits. You got to find the balance. But yeah, we've had that for 11 years. You know what I'm talking about, Monique? Oh, I'm like, wait a minute. So I got a PTA here who's got 2 visits today, and you're telling me you're jam-packed and can't do an admit. I think some of these are going to move.
I'm going to drink my water and mind my business.
or the therapist that's like, I got a full day, but they're all regular visits. I'm like, we can move some of those visits to accommodate the evals.
And then there's 2 canceled, but you don't find that out till the next day.
Yeah.
Then it's like, okay.
Playing the games.
Yeah.
So, my next question to you: we all know that there are going to be cuts in payment for agencies. And during the PDGM era, a lot of agencies let go of therapists, PTAs, and physical therapists. Some even cut their salary. So, with the further cuts that are going to be coming, what advice would you give to clinicians knowing that this might happen again to them?
Well, I think if we can still remember life before the pandemic, in February of 2020, and I believe that was the last in-person Hot Topics. That is
Mhm.
when the Medicare Learning Network put out a specific document about therapy utilization in PDGM. And it was almost like they saw what happened in the nursing homes because they started their new payment in October and then January, and immediately came out with nothing about coverage criteria for the Medicare Part A home health benefit has changed. Nothing. So the expectation is patients are getting what they need in this payment model. And they clarify that the payment groups in PDGM were built on the historical cost. So therapy utilization, as it was in 2018 and 2019, at its height, that cost is what they use to build these payment groups. Now, it's not a perfect model. Obviously, there's some you win and some you lose the way the math works out, but they accounted for a continuation of that level of therapy need. Unfortunately, they already started to see that drop in late 2019. As you said, people panicking, letting them go. 2020, they come out with this statement in March, in February. By March, we start seeing the pandemic, and now there's a big question about how much of utilization change was PDGM, how much of it was COVID. But what's interesting, some of the data coming out now is nursing use is now on the uptick. In many cases, therapy has gone down and stayed down, which I think again could be partially COVID related. I still think we're in the beginning of the wave of the rehab part of COVID. Initial was a lot of crisis management, keep people alive, manage their acute illness. I think things like long COVID and that are going to up the ante on the rehabilitation needs of this population going forward. But I know that the proposed rule for 2023 for skilled nursing facilities just dropped, and they're looking at an over 4% reduction, which has many on the home health side concerned, could it be the same? Now, there's a lot of advocacy about, how the costs have skyrocketed in home health very differently than in facility-based care, between gasoline prices and all of this. I'm sure you guys are feeling that. You're trying to get staff and the staffing situation. I think what it's going to take is very clear participation of anyone and everyone to be able to provide comments to our proposed rule. I think we've historically seen the more comments we get from frontline care providers, the more we're able to move the needle with CMS. That's partially what happened with value-based purchasing. They wanted to go to full implementation in 2022. They scooted it out a little bit to have essentially a practice year with financial implications going a year down the road. That was because of advocacy and comments. And I tell people all the time, the home health section, writing a comment is great. It's one comment. If the three of us write comments, that's 3 comments. And historically, the more comments they get with how this would impact patients, they do actually listen to that. So I think it's the interesting to see what the rule says, but I think efforts of your podcast in the future and the people that you touch, we're going to have a grassroots. This is what's going on, particularly because there seems to be a recurring theme of we've noticed what happened to your therapy, which is concerning. And I think therapists talking about what has happened to them as part of the comments could be a huge part of, yes, part of it's COVID, but I don't think we're going to get very far just blaming it all on COVID. Clearly, what you guys were
Do you
saying,
think
what we saw leading up to it was scary.
do you think we missed out on opportunity to show our true value during the COVID epidemic as physical therapists?
Again, I think we had our hands tied in home health in a way different than facilities. I mean, we had ALFs that wouldn't let us in. We had families that wouldn't let us in. They're sick. I'll take the nurse. I don't want therapy. They feel lousy. We're back to the spandex wearers. We don't want them. They feel terrible. So we'll just do that later when they feel better again.
Mhm.
Yeah, and then there's long COVID. You're not feeling better again. So I think that there's lessons learned. I think we could always armchair quarterback it and say there's parts we could have done better. The whole, I'll just sit on the sidelines in my silo didn't tee us up well either. But I think value-based purchasing and some of those Oasis E items give us an opportunity to say, okay, whatever happened, happened. What are we going to do going forward? What is my value? What am I doing? It's meaningful to keep people out of the hospital, because if I don't manage how they feed that cat, she's going to bend over, do it, break a hip, go to the hospital, and now we have a much bigger issue. And maintenance therapy, okay, maybe I'm not comfortable with it, but I'm going to have to get comfortable with it, because it is also a tool that keeps people out of skilled nursing facilities and out of the hospital. And if I can just say this, because this is just pinging me, I'm now running into therapists that are like, oh, I understand maintenance, I'm just not going to do it. I don't want to do it. And I've said, okay, no, that's fine. In home health agencies, you can make a decision that you don't do wound care. That is absolutely fine. The thing is, when a patient shows up that needs wound care, you can't ignore it. You can't go, I just don't do wound care. I'll just do with the rest of it. I don't look at the wound because it's okay, wait a second. If I don't want to do maintenance, that's fine. But then I need to know what it is, because when a patient would benefit from it, then I need to refer them out. I need to refer them to a therapist that will do it, or I need to send them to an agency that does do it, because we're now 10 years past the Jimmo decision. I can't believe we're still having what is that? I don't want to do it. I don't like it. Oh, I do it. It means I keep people for 10 years. No, it is about stabilizing function. And stabilizing function can be a huge piece of managing the patients that we see in home care now, especially with all the onslaught of people coming out, with the COVID related issues. Maintenance can be huge in keeping them out of higher cost care.
Absolutely.
Well, I think there has been a huge misconception about maintenance, because like when I first started doing home health, maintenance was considered non-skilled therapy. And when a lot of therapists say non-skilled, they feel that they're committing Medicare fraud and they don't want to do it. Sometimes some of them get bored or frustrated with providing care to patients that they know are going to keep progressively declining. So I think agencies didn't do a good job of describing or elaborating on what maintenance should, or the value of maintenance, because we have to sell value.
Correct.
I've had patients who have had MS for over 30 years, 20 years, and I still go and give them treatment, whether it's once a week, and they're maintaining their function. They're not declining as fast. So there are some benefits to it as well.
Well, I think it really is about reframing the conversation, because the word maintenance makes people uncomfortable for a variety of reasons. So I try to not use it. Let's just call it what it is. It's a stabilization approach to function, that I am trying to prevent something from coming off the rails. And so it can be for MS patients. It can be for heart failure patients. It can be for arthritic patients. The bottom line is, you don't have to be bedbound for this. This is really, I'm saying, I know things based on my training and expertise that will help you preserve the function that you have. And it still has to be skilled. You hit something, Monique, because people will still say, are you talking about skilled care or maintenance? Oh gosh, the word "or" now is a problem, because you're basically saying it's not skilled. There's a huge amount of skill in terms of how you're dosing these activities to stabilize function. But at the end of the day, if there's nothing left for me to teach, train, or do, I can't just do this to be nice. I can't keep seeing you because your wife can't do the program. Back to the social worker. Let's find somebody who can do this program with them, because it doesn't really take a therapist. So I know maintenance is a multifaceted issue, but I think that the time of, I just don't want to, I don't like it. Again, if that's your choice, great, but you still need to be informed enough to know when to refer a patient to that appropriate level of care. If it's not you, then who is it going to be? Because to just say, I don't like it, so nobody gets it, it's kind of like, nah. Just like when people pull that scope of practice issue about medications, That is not in my scope of practice. Okay, Jedi mind trick. The thing is, when you say scope of practice, you're taking out the entire profession. There's a big difference between scope of practice and personal competence. There's parts of what's in my licensure that I should not be doing on people because I am rusty and it would be dangerous. But I'm not going to say you two can't do it because I'm not comfortable doing it. That's a big difference. So I see that with maintenance too. I just, it's not my thing. Then you still have to
Okay.
know what to look for.
So my next hot and button issue is that so I've been in home health since 2012, and I've rarely seen physical therapists being in upper management. You don't have many physical therapists as clinical managers. They might give you the title of a lead therapist or rehab director or rehab supervisor, but most of the clinical managers, if not all of them, are nurses. And sometimes they don't understand that dynamic
Right.
of a physical therapist. So there are often challenges physical therapists will have with these clinical managers. And as I see Alex reporting a lot when he gets a phone call about his Oasis documentation. So to correct certain things that he knows he documented accurately, it can be a tad bit frustrating. I used to go back and forth with one of my clinical managers, but once they knew that I gave a solid and competent reason for why I chose this plan of care and the visit frequency, they just usually accepted it. So they know that
Right.
I wasn't just putting visits because because I'm pretty much paid per visit. But I also need to know which agency pays $250 per visit because I need to sign up as soon as possible.
But I think that there's a practical reason, and I'm just going to say it, why we don't see more therapists in those roles is they can make more money seeing patients. So I see a lot of therapists say, we're not represented. Okay, is it going to be you? Nope, because it's a pay cut. What you pay to work in quality, it's a pay cut. Being a clinical manager, pay cut. So it's kind of like, okay, again, I totally understand that. But then you can't keep complaining that there's no therapist in that role because you wouldn't do it either. So it's kind of like that's the rock and the hard place of there are opportunities. I see agencies on the regular that are open door policy about they love a therapist in that kind of role. I talked to one this week who the one who supervises the nurses is an OT. They welcome that, but again, it's a path you got to look at individually and say, in some cases, and in a lot of those cases, it's a pay cut compared to what I could get seeing patients. So how far do I want to go with that? On the flip side, though, as someone who sleeps with Oasis under their pillow, there are times where it was more so with in-person training. To deal with a room full of nurses to talk about Oasis, which is discipline neutral, they would have a problem. They'd look at the name up front and say, oh, that's a therapist. They'd see my initials and say, oh, that's a therapist. Like this wasn't going to apply to them. So several times I started just dropping off the initials and just left the name and this, and they'd be all listening and learning. And then we get to the functional questions and somebody go, are you a therapist? What now? Is my therapistness showing? Does this suddenly change the dynamic? Because it shouldn't. I don't need to wear a disguise. But yeah, I think it's an industry that has had such a history of being nursing heavy and nursing focused. But again, our profession, OT and speech, you want to crack that wall? And it's like, yeah, I like my check. So it is part of the decision making.
And that's a great point. I mean, again, some of us enjoy the home health for the flexibility and the money and going into a sort of administrative role, as much as there is potential for the representation and kind of putting your 2 cents into it. It does boil down to, I mean, I know I can speak for myself to say, that I would not take on a role like that for the simple reason that A, I can make more money seeing patients.
Right.
B, when I leave, when I'm done with my last patient, I'm done. Right? I can go home to my wife and my kids and I
Correct.
can do all that. Whereas typically you start doing some of this administrative stuff, it's more time demanding. And sometimes you don't get simply to just say, hey, work stays at work. I got to come and deal with some other things. So yeah, there's two sides to everything. And
I think it's important we just own it. It's not a judgment. It's not a criticism. It's just it's part of the decision. But I think then we have to look at it and say, what are my other opportunities? Is it periodically doing peer review? Can I do an in-service on something? Can I educate on what therapists do? Can I get in front of them in a way that doesn't commit me to 40 hours of meetings and paperwork, but still gives a therapy voice and helps people better understand? I think all of us could do more of that in a way that doesn't, cut our pay significantly, but still gives us that visibility, because without that kind of visibility, I think they kind of just forget we exist. We're out there making visits and whatever. And my son says that now they came up with a brand new plan to schedule, and he goes, it is not going to work for therapy. He goes, it's not. That's just not how we do it. There was no therapist at the meeting. No therapist participated. Maybe on a project, we need to say, listen, I'll come in a couple hours. Can we just talk about this? Because it's just different. It's not that it's wrong, but sometimes what really works good for how you're wired and set up just does not automatically translate over here.
Absolutely.
Just like when he calls me and he'll
What?
say, I had 21 patients on my schedule today. And I'm like, what? He goes, well, I have all the patients and then we're supposed to just sort it out. I said, okay, PTA, how do you sort it out? I mean, there are just 21 names on a list. Yeah, your scheduling thing might need some work.
Yeah.
Definitely. So, what led you into consulting?
I can't keep my mouth shut. I can't. Let's just put it this way. Okay. At one point, I did try a PRN job at a skilled nursing facility. Let's just say they let me go, because I kept saying, wait a minute. So you haven't provided therapy to this person for 30 days and let her lay in bed till she crossed some magic thing that if we do it now, you'll get paid better? That's horrible. And this lady was arguing with me that she knew she could get out of that chair if I would just let her pull on the walker. So, the home health person that I'm at, okay, let's stabilize the walker. Let's see what you got. And my boss, the OT, was horrified. You can't do that. I said, I just want to see what she can do. And she couldn't. She could not get up that way. And now she knew she couldn't go up that way. And for the first time in 30 days, she used her feet to reel herself down the hallway, because I said, you want to get better at this. This is what you're going to have to do. I got chewed out for, why'd you let her pull on a walker? That's not a safe way to use it. I wasn't instructing her to use it. I was proving a point that in her mind, that was the way that would fix it. And now that she sees it doesn't work, now she's going to do. So it's that kind of stuff where I go, what rule are you talking about? Wait a minute. What did you say that has to be done? Let's talk about that some more. Because I enjoy now, it's kind of the same. I told a person earlier today, I still treat consulting like a care plan. There's not a one size fits all. What's going on with your organization or your team? What works? What doesn't? How do we get you where you want to be? And I think what makes us a bit different is I think my therapiness bleeds over. I don't want to be codependent. I'm not a consultant that wants to have you call me every day for the rest of your existence. No therapist does. That's why we're therapists. Here, what the tools do you need? Here's the tools. Learn to use the tools. Fly birdie and be successful. So I get enjoyment from that, and also trying to balance some of that nursing focus with almost being an interpreter for therapy. That no, they're not really fighting you about maintenance. They're really struggling with, if everything's been improvement before now, making that change is hard. It's hard to rewire yourself. They're not being difficult. But then I also get the calls that say, would you come to my agency and knock my therapist off their pedestal? To which I usually say, you understand you help put them up there, right? I mean, no therapist jumps on the pedestal. You
Yeah.
said you didn't have to do admits, you didn't have to work weekends, you never had to see more than 5 people, you never had to come in the office. Now you're trying to change that, and they're pushing back. There's a reason. So I enjoy that rehab in a different way, but also trying to get a therapy voice into conversations that can very easily become nursing. And then I look at it as I'm trying to keep the door open so that the therapists that are there can be better understood.
Okay.
Good deal.
So how can people reach you and K&K Krafft?
Well, I put my Twitter handle thing. Yes, did that come up correctly? My
Yes.
lack of social media skills is showing right here. My email address is Krafft, and yes, it is KRAFFT. You drop an F, the email goes nowhere. Okay, this happens, Alex, when I check into hotels. Krafft with a K. It has 2 F's. Are you sure?
No, it's just my name.
Been my name for 30 years now. I think I know how to spell it. So it's KRAFFT at ValueBeyondTheVisit.com. It's long, but it's fairly easy to remember.
Absolutely, absolutely. Well, it's been a
I think I posted it, so hopefully that is correct in the chat. Yeah.
yeah. Well, it's been a pleasure to have you on. I mean, I know I learned a few things today, which is awesome. I've been doing home health for 8 years now. But to always learn something new every day, and it's been very awesome. So thank you very much for taking the time to be with us and dropping some gems for us and for our viewers. Yeah, that was awesome. Thank you very much.
Anytime. I thoroughly enjoyed myself. I miss hanging out with other PTs. I will say it's just nice to be, okay, so I'm not the lone crazy person screaming in the wind some days. But anytime, and technically nothing went wrong. I've had my share of that, doing virtual stuff during COVID, of power failures and internet failures and all kinds of stuff. So I'm glad all of that was nice and smooth this evening.
Yes, thank you so very much, and I hope you enjoy the rest of the evening. You guys can revisit this on our YouTube channel. The episode will be on our Twitter page and as well on our website. So again, don't forget to subscribe. Thank you again, Cindy. And if any one of you needs to reach out to her, Krafft at ValueBeyondTheVisit.com. She won't steer you wrong. She's honestly made me a better clinician and
Thank
my
you.
practice better. So
Awesome.
thank you guys.
Thank you.
Have a great
Thank you.
evening.
Everybody have a good night.
Bye.